Today we are going to perform the neurological examination of the lower limbs. So, to start with, we will be doing the gait of the patient and then followed by the patient on the bed doing the inspection, palpation, and then checking the tone, power, reflexes, and the sensory system along with the coordination. Dr. Mithun has kindly volunteered to be the patient today. So we are going to first check the gait. So Mithun, can you walk normally, your normal walking? Come back. Can you walk fast? Come back in the same. Right. Okay. Now I want you to walk on tiptoes. Come back. Can you walk on heels now? On your heels? Come back. And now I want you to walk on your insides of the feet. Okay. Now, can you walk from your outsides of the feet? That is called the fog and the reverse fog. So when you do these methods of walking, you can see any changes in his walking as well as the use of his hands in walking, etc. And can you walk on a line now, 1 foot after the other? This is the tandem walking. If there is any incoordination, then he is unable to do this tandem walking. Okay. So now I'm going to check the Gowers test. Mithun, can you sit on the floor? Yes. Okay. Now can you stand up? Yes. So he didn't have any problem in standing up. But when it's the Gowers test positive, they have difficulties due to proximal muscle weakness. Right. Now I'm going to check his coordination again. Mithun, can you keep your feet together? Right. Keep your hands straight and close your eyes. So one has to be mindful that the patient might fall.
So here we are checking his posterior columns, the Romberg sign.
Okay, Mithun, open your eyes. Right. And do you feel any imbalance or difficulty?
No.
No. Right. Now you can see that Mithun is standing straight and he doesn't have any ataxia or any imbalance. Okay, so let's move on to the other examination while he's being put onto the bed. To complete the examination of the lower limbs, you need to check the patient's back and the anal and the bladder tone. So I'm going to check Mithun's back. Can you turn to this side, Mithun, and lift your t-shirt? Yes. So just observe first up to the level of the lumbar region, lumbosacral region, whether there's any deformities or surgical scars or any other tuft of hair or anything. And then just feel your finger down the spine just to see if there is any anatomical abnormality. And at the same time, you need to check the tone of the anus and the palpable bladder. When performing the neurological examination of the lower limbs, you need to expose the patient to preserve his or her privacy. So you have to get a good exposure up to at least to the level of the mid-thigh to check, see all the muscles that are involved with lower limb function. So I would be starting on the inspection of the lower limbs. So what do you want to start? When you start with the inspection, what are the things that are important? That is the muscle bulk, whether there's any wasting, whether there's any scars, or whether there's any trophic ulcers. So I'm going to check for any scars, any muscle wasting over the thigh and the knee, and also any trophic ulcers that are present in the lower part of the feet. And then if you want to check for, if there's any wasting, if you want to check for any fasciculation, you can just tap slightly on the skin to observe for any fasciculations. I can't see any fasciculations in him. So his lower limbs are, the muscle power, muscle bulk is normal. There are no trophic ulcers, and there's no skin changes, and there are no release scars. Therefore, I would now proceed to go ahead with the tone of the lower limbs. So next, we will proceed to check the tone of the lower limbs. So you can check the tone by relaxing the limb. Mithun Podak, shall we relax a little bit? Yeah. So by relaxing and then rolling the lower limb, and then try to lift the lower limb from the knee. So if there was a hypertonia, the lower limb would flip upwards like this. And if there is a hypotonia, you will feel, it's a feeling that the lower limb is very floppy. So you would do the same thing to the other side as well. Relax Mithun. Right? So I'm just rolling a little bit and then trying to lift it. So you can see that his lower limbs are normal in tone. Another way of performing this is you try to check each and individual joints. You try to flex the knee joint, relax, and then try flexing and extending the knee joint so that you will feel the tone of the knee joint. And also the same to the ankle joint. You can rotate the ankle joint and also do a little bit of flexion and extension to see the tone of the ankle joint. So in this situation, the tone of the ankle and the knee joints are normal. So in overall, the lower limb tone is normal in Mithun. Next, we are going to check the clonus of the knee joint and also the ankle joint. To perform this, you need to make a fist and then keep it under the knee joint, and then ask the patient to relax, Mithun, relax. And then from your other hand, just hold the patella, and then you have to press it downwards quickly. So relax, Mithun. I'm stabilizing the knee joint with my fist and then trying to give a push to the patella. Then you do the same to the other side. Relax. You feel the patella and then give a harsh push to the patella. You can repeat it once more. Right. So there's no patellar clonus in this patient. Going on to the ankle clonus, again, you need to keep the knee flexed and the ankle flexed to 90 degrees, and relax the lower limb, relax, and then hold the ankle from your hand and then give a quick dorsiflexion to the ankle. Up to 1 to 2 beats are normal in a normal patient, and you do the same to the other side as well. Relax. So I felt about 2 beats there, but that's a normal ankle pronus. Okay, the next level of testing would be the power of the muscle groups in the lower limbs. So here we are basically testing the main muscle groups in the hips. That's the flexion, extension, adduction, and abduction of the hips. And at the knee joint, the flexion and the extension. And at the ankle joint, it will be again dorsiflexion and plantar flexion, inversion and eversion. So to check the hip group muscles, I would first ask Mithun to flex at the hip without bending at the knee. Can you lift, Mithun? Yes. So he can lift his leg above against the gravity. Okay, keep it down. So now I'm going to check how he will do it against the resistance. Now, the grading, MRC grading of the muscle power is graded at 0 to 5, and that will be explained to you. And I will ask Mithun to lift his leg without bending at the knee joint, where I'm checking the hip flexion. Can you lift the leg and try to push against my resistance? So his power, he can do it against resistance, and it is a normal power, that is a grade 5 MRC grade 5 power. And you do the same to the other side as well. Yes. And against resistance, and it's a normal MRC grade 5 power. And as much as possible, if you're using your left hand, try to use the same hand, because otherwise there may be discrepancies if you're using both hands at the same time. So for the extension, lift the leg, Mithun. I'm not letting him to push the leg down, but I'm asking him to push the leg down against my hand resistance. So this is the hip extension. So this is again grade MRC grade 5 power. Push the leg down. Yeah, MRC grade 5. So hips flexion and extension here, grade 5.
The flexors of the hip joint: iliacus, psoas major, supplied by the lumboventral rami; the rectus femoris, sartorius; pectineus, supplied by the femoral nerve; adductor longus, supplied by the obturator nerve; tensor fasciae lata, supplied by the superior gluteal nerve. The extensors of the hip joint: the gluteus maximus, supplied by the inferior gluteal nerve; bicep femoris, long head; semi-tendinous; semimembranosus; adductor magnus, supplied by the tibial part of the sciatic nerve.
Now we are going to check the abduction and the adduction of the hip joint muscle groups. So to check the abduction, you ask the patient to part the legs, to abduct the legs. Mithun, can you press against my hands outside? Put your legs outside. So here he's putting the pressure, and it's a normal pressure. So that's the MRC grade 5 power in the abduction. Then adduction is taking the legs closer by the adductor muscles. So I would keep my hands like this and ask him to take the legs towards each other. So again, it's a grade 5 MRC power here. So we have checked the flexion, extension, adduction and the abduction of the hip joint muscle groups that are being used in the functions.
The adductors of the hip joint: adductor longus, adductor magnus, and underneath adductor brevis. The gracilis all are supplied by the obturator nerve. The pectineus supplied by the femoral nerve. On the posterior aspect, the quadratus femoris supplied by L4, L5, S1 ventral rami. The abductors of the hip joint: the gluteus medius, gluteus minimus supplied by the superior gluteal nerve. The tensor fasciae lata supplied by the superior gluteal nerve. The piriformis supplied by L5, S1, S2 ventral rami. In flexion, the obturator's internals play a role, supplied by L5, S1, S2 ventral rami.
So next we'll be checking the power of the knee joint muscles. So basically we are checking the extension and the flexion of the knee joint. Mithun, can you bend the knee? Right. Now can you push your knee? Push my hand. Okay. And now now pull your knee towards your thigh. Okay. Right. Now the other leg. Now push my hand and now pull your knee towards your thigh. Right. Okay. That's the flexion and the extension of the knee joint.
The flexors of the knee joint: sartorius supplied by the femoral nerve. Gracilis supplied by the obturator nerve. Semimembranosus, semitendinous, the long head of the bicep femoris supplied by the tibial part of the sciatic nerve. The short head of the bicep femoris supplied by the common peroneal branch of the sciatic nerve. The popliteus supplied by the tibial nerve. The gastrocnemius supplied by the tibial nerve. The extensors of the knee joint: vastus medialis, vastus lateralis, the rectus femoris. Underneath that, vastus intermedialis supplied by the femoral nerve. The tensor fasciae lata supplied by the superior gluteal nerve. On the posterior aspect, the gluteus maximus supplied by the inferior gluteal nerve.
Next, we will move on to the ankle joint. Now, ankle joint has four components. That's the dorsiflexion, plantar flexion, inversion, and the eversion. So, I would ask Mithun to not to let me push towards his face. So, push his ankle towards him. So, I'm just trying to push. So this is plantar flexion. And Mithun, can you please push my hand towards your face? So this is, I am trying the power of the dorsiflexion.
The plantar flexion at the ankle joint: gastrocnemius, soleus, the plantalis, the tibialis posterior, flexor digitorum longus, flexor hallucis longus, all are supplied by the tibial nerve. Peroneus longus and peroneus brevis supplied by the superficial peroneal nerve. The dorsiflexion at the ankle joint: tibialis anterior, extensor digitorum longus, extensor hallucis longus, peroneus tertius. All are supplied by the deep peroneal nerve.
And I will be checking individually in the right big toe or the big toes because it is innervated by the L5. Can you turn your big toe towards your face? Towards your face, this side? Yeah. No, up. Turn up. Turn up. Yeah. Don't let me push it down. Right? Right. Again, this one. Up. Keep it up. Don't let me push it down. Right. So that's L5. Now, the inversion and the eversion. So I'm just trying to keep the feet inverted, and I'm asking Mithun to push me out. Mithun, push me out. Try to open up your feet. Try to open up your feet. Right, that is inversion. Yeah, open up. Right, and then I will keep let me keep the legs on this position, up this side. And don't let me, you keep it like this, don't let me take it towards the midline, right? You keep it like that. This is, I'm checking the power of the eversion. Okay, ask him to evert, keep it everted, but not to let me push it towards the inversion. So eversion and inversion, dorsiflexion and plantar flexion, and the flexion of the big toe are all normal in power, that is MRC grade 5.
The movements of the tarsal joints, particularly talocalcaneonavicular joint, inversion. Tibialis anterior, extensor, hallucis longus, both supplied by the deep peroneal nerve. On the posterior aspect, tibialis posterior, supplied by the tibial nerve. The eversion, peroneus longus, peroneus brevis, supplied by the superficial peroneal nerve. Extensor digitorum longus, the lateral part, and the peroneus tertius, supplied by the deep peroneal nerve.
So the next item is that we are going to check the reflexes. So here we are checking the knee jerk and the ankle jerk. So for that we are using this patella hammer or the knee hammer, which is a flexible one. And when you're holding the knee hammer, you have to hold it from the edge of the knee hammer. And first, again, the patient has to be relaxed. So I'm asking Mithun to be relaxed. And I have to feel the patellar tendon here. That is where I need to hit. And I will be looking at the muscles in the anterior thigh. So here I'm going to, now I have felt it and I'm going to so you can see that the muscles are contracting and there is a jerk. Now the other side, again I'm feeling for the tendon and I'm feeling and then hitting the proper place and in the proper manner where you have to hold the knee hammer from the edge. And you can see the contraction of the muscles and also the jerk. So the knee jerks are present and they are in normal intensity. If the knee jerk doesn't come or if the knee jerk is difficult to elicit, you straight away you cannot say that the knee jerk is absent unless you perform the Gendrasik maneuver. That is to keep your hands locked in that position and ask the patient to hook once you are trying to hit the tendon. So, okay, Mithun, keep the hands like that. When I ask you to hook, please hook the hands. Right, okay, Mithun. Right, so you can see that the knee jerk came in very easily with the Gendrasik maneuver. So it's again a normal knee reflex. Next, we are going to check the ankle reflex. So I'm going to keep this leg on his other lower limb so that his right leg is relaxed, and I will be holding the feet from his a little bit dorsiflexed and but not tightening, and ask the patient to relax. Mithun, relax. And I feel the tendon is here, the Achilles tendon, which is nicely seen there, and hold the knee hammer from the edge, and I'm just trying to tap at the tendon. So you can see that the muscles, gastrocnemius and the soleus, are contracting, and also if you can see clearly that the jerk of the ankle as well. Okay, so the left leg is relaxing on the right leg. Feet, I'm holding from the toes, slightly on the dorsiflex position, and I feel the tendon here, that's the tendo Achilles, and then holding the knee hammer like this, I'm going to tap the tendon. So you can see that there is a contracture of the gastrocnemius and the soleus, and also Mithun, can you keep your hands joint like that? So again, the Gendrasic maneuver will help because the knee jerk didn't come across that clearly. So I'm asking Mithun to hook now, Mithun. Hook. So you can see that the ankle jerk is coming there when he is hooking, and the Gendrasic maneuver is on. Next, we are going to check the plantar reflex. The plantar reflex is checked by stroking the lateral side of the feet with your thumb or an orange stick or a blunt edge of a toothpick like this. You have to be mindful that some patients are very hypersensitive. So you should not use the edge of the knee hammer, which has a sharp edge, and also better avoid a car key as well. So as much as possible, try to use your thumb. When checking the plantar reflex, I'm using my thumb to stroke the lateral angle of the feet. So I'm coming like this, and then you observe the response, which is a flexor response in this patient. So I'm doing the same to the other side. It's again a flexor response. You could even use the blunt side of the toothpick. Very gently, you have to do the stroking there. So let's check for the abdominal reflexes, superficial abdominal reflexes, where you use the blunt side of a toothpick to stroke from 4 sides of the abdomen towards the midline. And then you will see the abdominal muscles contracting. This has to be done very gently. So you can see that the abdominal muscles are contracting.
Let me describe the dermatomes of the lower limb. The lower limb is supplied by the anterior primary rami of L1 to L5 and S1 to S3. The exception for this rule is the superior medial aspect of the gluteal region, which is supplied by the posterior primary rami of L1 to L3 and S1 to S3. There is varying degree of overlapping of adjoining dermatomes, so that the area of sensory loss following a damage to the spinal cord or a nerve root is always less than the actual area of the dermatome. During the development, each limb bud has a cephalic border and a caudal border. These are known as preaxial and postaxial borders, respectively. In the embryo, great toe and tibia lies along the preaxial border, and the little toe and fibula along the postaxial border. Later, the limb rotates medially through 90 degrees, so that the great toe and the tibia are carried medially, and the little toe and the fibula moves laterally. Thus, the tibial border is the original preaxial border, and the fibula border is the
postaxial border of the lower limb. Now we will look at the anterior aspect of the lower limb for its dermatomal distribution. The L1 segment usually covers the upper one-third of the anterior aspect of the thigh. The L2 segments usually start just below the greater trochanter and runs downwards towards the lower one-fifth of the thigh. The L3 segments usually starts at the midway of the femur and it runs across the knee and stops just below the medial tibial condyle. The L4 starts from there and it covers the medial aspect of the leg and covers the medial malleolus. The L5 covers the lateral aspect of the leg where it starts just below the L3 and it runs diagonally, and as you can see it covers the first, second and the third toes including their nail beds. The S1 covers the fourth and the fifth toe including the lateral border of the foot. Now let me describe the ventral and dorsal axial line as shown in this diagram. As the lower limb elongates, the central dermatomes such as L4, L5, S1 get pulled in such a way that these are represented only in the distal part of the lower limb and are buried proximally. The line along which the central dermatomes are buried is known as the axial line. In fact, the axial line is defined as a line along the certain dermatomes are buried or missing. So the distant dermatomes adjoin each other. Overlapping of the dermatomes in these areas are very minimal. There are two axial lines, one ventral and one dorsal, both of which extends largely on the posterior aspect of the lower limb. On the posterior surface of the lower limb, the ventral axial line extends up to the heel, whereas the dorsal axial line ends up at a higher level at the junction of the upper two-thirds and the lower one-third of the leg. On the anterior surface of the limb, the ventral axial line crosses the scrotum and the dorsal axial line encroaches the lateral side of the knee.
When you want to check the pain sensation, you can use the blunt side of the toothpick in the areas that we check pain, that is the dermatomal areas. And if you want to check the light touch, you can use a whisk of cotton wool. So both these will have to be checked in each and every dermatome and come to a consensus. So we are going to check the sensory of the lower limb now. So before going on to the sensory, we will check the normal sensory level at the midline in the face. So, Mithun, can you feel?
Yes.
Yes. Right. Or else you can check at the siphisternum, check in the midline. Can you feel?
Yes, ma'am.
Yes. Now, when you are checking the sensory, we are going according to the dermatomes. So, dermatome. The lower limb dermatome start with L1. So the L1 is this area. So I'm going to check L1 like this. Just one prick would be enough.
And then I go to the medial side, which is L3, the lateral side, which is L2.
And then again the medial side is L4.
Yes.
And L5 would be the lateral side of the leg.
Yes.
And then your big toe is also L5.
Yes.
So I'm going to check the other side as well. Similarly,
Yes.
L1 here. Now, if you want to see a discrepancy, you want to check both sides. Is there any difference, Mithun?
No.
No, right. So, and then again, similarly, L2, L3, L4 and L5 up to the big toe. So S1 at the sole, S2 up to this level, so that's a wider area, and then S3, S4, S5 are at the perineal region. When you want to check the joint position sense, it is necessary to check it in a bigger sort of a toe. So I would take the big toe for that, and we have to explain the patient. Ideally, you should stabilize the joint with your 2 fingers, and you are manipulating with this part of the toe. That's the top part of the toe. When you're holding the big toe, the joint has to be fixed with your thumb and the index finger of one hand, and the joint from the sides like this from the thumb and index finger of the other hand. So you should not touch the joint like this. That is the thumb on the nail and the nail bed, and also you should not use one hand to do this. So the best way is to hold it like this from both sides and while stabilizing the joint. So I would explain to Mithun. Mithun, can you look at this? So now this is up, this is down, and this is neutral, right? And you have to ask the patient to close the eyes afterwards. And then you move it in a random way and ask where the big toe is now. Can you say whether it's down or up?
Down.
Okay.
Up. Down.
Okay, so 3 times is enough. If you have got correct 3 answers, then the joint position sense is intact. So similarly, you stabilize the joint and then move with the 2 fingers of the other hand.
Down. Down. Up.
So he has given correct answers in 3 instances. So his joint position sense is intact in both sides of the lower limbs. So now we are going to check the coordination of the lower limbs. So Mithun, I'm just going to let you share how to do this coordination procedure. Lift your leg like this. Keep it on the knee of the right leg and try to drag it along the shin, and then again lift it and then knee and drag it along. Can you do it yourself? Okay, right. So then we'll do it for the other leg as well. Right, okay. So the coordination is normal here. If the coordination is abnormal, there will be clumsiness in trying to drag the feet along the shin.